Okay, thank you very much for that. I'm going to talk on a very constrained area compared to Richard, and I'm going to try and give a message on SGLT2 inhibitors in diabetic nephropathy in an accessible form, I hope. But there's going to be some renal physiology. So that's a warning, but I would like to say how great it is to see so many of our ex-trainees from the Northeast here and to meet them all last night, and I apologize for my failing memory as I get older to remember all of the details of your training record, but it's very great to see you all, and I would like to thank the organizers for inviting me to this talk. Okay. I'm going to introduce a little bit about the problem of end-stage renal disease in India, because really the whole point of SGLT2 inhibition is to try and prevent people going into kidney failure. And the latest data I could come up with when I was preparing this talk was that the estimated incidence in 2013 was around 232 per million population. And this would mean that India was in the top 10 worldwide of people, of countries in terms of incidence of end-stage renal disease. Now, I've just spent 2.5 years in Malaysia, where I was clinical dean in Newcastle University, and Malaysia has the unenviable distinction of being the second or third in the world. But India is up there with them, and this seems to be a particular problem for Asian countries. And although it doesn't sound very much, the Global Burden of Disease report suggested that renal failure accounted for 2.9% of all mortality in adults above the age of 15, and it's the 8th leading cause of death. And diabetes is at least 1/3 of the cause of end-stage renal disease in India. And the figures from 2013 suggested that with just 2 hemodialysis sessions a week or peritoneal dialysis, the cost around 30,000 rupees a month, which is well beyond the access of many Indian people, unfortunately. So it's expensive, and we should prevent it if we can. Now, just a brief outline of the possible causative pathways that lead to end-stage renal disease in diabetes. And one of the luminaries in this area is Mark Cooper, and a few years ago he published this schematic where there are basically 3 underlying initiating pathways, one of which is a hemodynamic one, and we're going to talk a little bit about that more in respect to SGLT2 inhibition. There's a metabolic one, which is related to glycemic control, and there are genes. Now, just like with hypogonadotrophic hypogonadism, several genes have been found with regard to diabetic nephropathy, but no major gene effect has been discovered. In terms of metabolic pathways, then this is all around glucose control, and I'm not really going to talk about that this morning because the SGLT2 inhibitor effect is glucose independent. So we're going to talk about hemodynamics. Now, another brief slide on natural history of diabetic nephropathy. And what we've got here are on the my left-hand side, you can see on the vertical axis GFR, and on the right-hand side, you can see urinary albumin excretion in terms of grams per day. And what happens in nephropathy is that GFR is often high, but by no means in all patients with diabetes. The normal GFR for an adult is around about 120 to 140. And then in probably the majority of patients, it just declines with an age-related loss of about 1 ml per minute per year after the age of 40. So I've lost about 27 mLs per minute since I was 40 years old. But if you've got diabetes without nephropathy, it's about twice that rate. And if you've got albuminuria, it's about 4, 5, or 6 times that rate. And so as a result of that, when you develop nephropathy, you enter end-stage renal disease 20 to 30 years after you develop diabetes. And this is mirrored by an increasing albumin excretion rate. Now, this slide is a little bit complicated, and this is the renal physiology that that I mentioned in my introduction. And it's important because in order to understand the effect of SGLT2 inhibition, we need to go back to the physiology in the kidney. Now, we know that, sorry, we'll go back one. Can we go back one? Hang on, I've got it. Okay, so here we've got the glomerulus, and here is the afferent arteriole and the efferent arteriole. And these two blood vessels control the blood flow and the pressure within the glomerulus. In the normal, non-diabetic situation, the tone in these two is balanced, so you have normal filtration. The SGLT2 enzyme is here in the proximal convoluted tubule, and you get sodium, water, chloride, glucose reabsorption. There are minimal amounts of sodium and chloride reaching the distal convoluted tubule, and that sends a signal back to the glomerulus to maintain filtration. Now, in situations where you have altered delivery of sodium, chloride, and glucose, at the distal convoluted tubule, you affect the tubular-glomerular feedback. So if you move across to cartoon B, what happens in diabetes is that with the increased glucose filtration at the glomerulus, you have increased glucose presentation in the proximal tubule. This upregulates the SGLT2 enzyme. And this causes not only increased reabsorption of glucose, but also increased reabsorption of sodium and chloride. So that means that the amount of sodium and chloride at the distal tubule is reduced. And this is perceived by the juxtaglomerular apparatus as needing greater filtration. So you have afferent arteriolar vasodilatation. And as a result of that, you get increased flow through the glomerulus and increased filtration and increased pressure in the glomerular capillaries. So the increased presentation of glucose in the proximal tubule with the upregulation of the SGLT2 enzyme is deemed to be responsible for the increased glomerular filtration, or hyperfiltration as we call it, that we see in diabetes. Now, I hope that's relatively clear, because that's fundamental to understanding where we go next in terms of understanding SGLT2. So here is a cartoon which is meant to demonstrate a bit of what I've just been talking about. So in the top here, we've got the control situation where afferent and efferent glomerular arteriolar tone are balanced, renal blood flow is normal, and the filtration pressure is normal. If you have increased afferent arteriolar resistance, then renal blood flow is down and filtration pressure is down and GFR will go down. And NSAIDs are a classic example of how this occurs. In diabetes, we have decreased afferent arteriolar tone, so we have increased glomerular blood flow and increased pressure, which gives rise to hyperfiltration. And SGLT2 inhibition is said to correct this. In the situation where you have increased efferent arteriolar tone or constriction, such as induced by norepinephrine or angiotensin II, then blood flow will go down and the pressure will go up. And this is what we do in situations like sepsis or in the ITU. And with RAAS blockade, we relax the efferent arteriole, so we get decreased efferent arteriolar tone, the renal blood flow goes up, the pressure goes down, and this is how RAAS, renal angiotensin-aldosterone system blockade, works in diabetic nephropathy. So this protective therapy and this protective therapy are working on two sides of the glomerulus in terms of blood flow. Okay, well, I hope that's reasonably clear. Does it actually work in practice? Well, one of the luminaries of SGLT2 inhibition in diabetic nephropathy research is David Cherney from Toronto, and he showed that in people with type 1 diabetes who are hyperfiltering, that is the H group here, if you perform a euglycemic clamp and you use in a blinded fashion either empagliflozin or a baseline level, a baseline estimate, you'll find that empagliflozin will reduce the GFR in hyperfiltering patients, but have no effect on GFR in the normofiltering patients. And if you use a hyperglycemic clamp where you exaggerate the stimulus to the increased GFR in diabetes, then the same thing occurs. So this is proof of concept that SGLT2 inhibition will reduce the increased GFR that you see in patients with diabetes. So what about the impact on albuminuria, which is the other clinical feature of diabetic nephropathy? Well, David Cherney combined a series of data from different trials looking at empagliflozin in people with type 2 diabetes and microalbuminuria and those with macroalbuminuria, and I'll explain those terms in a bit more detail in a while. But essentially the message is the same, that SGLT2 inhibition reduces albumin excretion in patients with type 2 diabetes and elevated levels at baseline. So we have the theory, which is around the tubular glomerular feedback causing hyperfiltration in diabetes, which can be corrected by SGLT2, and we've shown that by doing direct measures of GFR, that blockade of SGLT2 corrects hyperfiltration. So we've got a concept, a theory or a hypothesis. We've shown that in the short term the agent works. What about in clinical practice? Now, in order to, before we discuss the major trials, 3 trials which I'm going to talk about in a moment, we need to understand what outcomes have been used in diabetic nephropathy trials. And traditionally, these revolved around albuminuria. And this is because if you cast your mind back to the natural history slide I showed a little while ago, nephropathy takes many years to develop, and you can't, in practice, have a clinical randomized trial over 10 or 15 years. It's just not feasible to do that. So we've had to use intermediary outcomes, and the traditional one has been albuminuria. And we've had either prevention of progression to overt nephropathy, which is defined as an albumin-creatinine ratio of more than 300 milligrams. That should be milligrams per day, which is albumin excretion rate, or 300 milligrams per gram of creatinine on an albumin-creatinine ratio. We've also talked about prevention of progression to microalbuminuria, which is 30 milligrams per day, regression from overt to micro, and regression from an overt and micro to normal albuminuria. Now, the problem is that the FDA and regulatory authorities do not recognize reduction of albuminuria as a valid endpoint for licensing drugs for prevention of nephropathy. So we've had to resort to measures of kidney function directly. So one of these has been a doubling of serum creatinine. If you double your serum creatinine, you halve your GFR. So if your serum creatinine goes from 100 to 200, then you've halved your GFR. A few years ago, the FDA allowed, apart from the doubling, a 40% reduction in estimated GFR from baseline as a valid measure for efficacy. And of course, we do have the much harder endpoints of end-stage renal disease, which means you go on to dialysis, you have a kidney transplant, or you're assessed to have kidney death. And the one slight problem with ESRD is that nephrologists vary in their indications for dialysis. It's not universal, but it's a pretty hard endpoint and one that's been accepted by the FDA. So these are the ones that are used for licensing, and that's why they appear in all the trials. Okay, so what about the data and what about the trial evidence that we have to date? Well, there are three main studies that I'm going to talk about: EMPA-REG Renal, CANVAS, and CREDENCE. And I've dealt with them in this order because this was the order in which they were published. You'll see that the number of participants in these trials was very large. Incredibly, the average age of all the participants was the same in all three studies, as was almost identical baseline HbA1c. And that was completely by accident. The eGFR levels were reported separately for EMPA-REG Renal. Around just over a half had between 60 to 90 mLs per 1.73 meters squared. For CANVAS, it was 77, and for CREDENCE, it was worse at about 56. The albumin-creatinine ratio was varied in EMPA-REG Renal. 59% were normal, 30% were microalbuminuric, 11% were macroalbuminuric, and the definitions are along the bottom here. In CANVAS, 70% were normal, and fewer had increased albuminuria at baseline. But in CREDENCE, all of them were macroalbuminuric. The durations of the trials were very similar, with a median of around about 2.5 years, but the discontinuation rates were really pretty high, anything from about 17% to 27%. So what about the renal outcomes? What happened to these patients in terms of their kidneys? Well, what we found was that the composite renal outcome, and I'll explain what that is for each individual slide, individual study shortly, per 100 patient years showed a benefit of empagliflozin, canagliflozin, and canagliflozin. The rates were much higher in CREDENCE because the severity of the renal disease at baseline was much higher in these patients. And I've broken it down. So, for example, the doubling of serum creatinine was 0.6% versus 1% in EMPA-REG Renal, 2.1% or 3.4% in the CREDENCE trial. And renal death, or cardiovascular death in parenthesis, was 0.3% versus 0.9% in CREDENCE, and for cardiovascular death, it was 1.9 versus 2.4%. So they all work. And this looks to be a class effect from the drugs, even though the SGLT2 versus SGLT1 ratio does differ between these different agents, but it does look to be a class effect. If we look at each trial separately, the renal-specific outcome was end-stage renal disease, doubling of serum creatinine, or renal death in EMPA-REG, and you can see that the difference here was around about 4 to 5%. It's always a worry when you see a blown-up figure of efficacy here when you look at the original, which is really pretty small. But nonetheless, this is statistically significant, even if the absolute numbers are not that huge. For CANVAS, we had a renal outcome of end-stage renal disease. In this case, it was a 40% reduction in eGFR, not a doubling of serum creatinine or renal death, and it was about a 4% absolute difference between placebo and canagliflozin. And for CREDENCE, it was about a 5% difference here, and the endpoint was end-stage renal disease, doubling of serum creatinine or renal death. So they're pretty much all showing the same thing, and with a similar magnitude of effect in all three trials. What about albuminuria? What happened to albumin excretion in these trials? Well, this is kind of interesting, because if we look at EMPA-REG, which is the only study really to publish detailed data, in those patients who were normoalbuminuric at baseline, there was a minor benefit of empagliflozin versus placebo. And if you look, there was no real effect, initial effect, on albumin excretion in these patients. And this is curious, because if the hypothesis is correct, and that reduction of GFR in early diabetes is a major benefit in terms of preventing the development of diabetic kidney disease, you would anticipate that these drugs would reduce the numbers of patients developing microalbuminuria in the early stages. And this did not happen. So we need to think about what this is telling us about the initiation of diabetic nephropathy. Is hyperfiltration a major player in the initiation of nephropathy, or is, as these trials are suggesting, perhaps it's a major player in the progression of diabetic nephropathy once you have the initial insult? And we don't know yet. But it's curious that we didn't see this effect in early stages, because when we look at patients who are microalbuminuric, we see an initial reduction and a stable reduction over the duration of the study. And if we look at those macroalbuminuric at baseline, it's exactly the same. Absolutely flat, but it's a sustained reduction throughout the course of the study. And Credence, which published just earlier this month, was exactly the same. Here we've got canagliflozin showing this flat but significant impact on albuminuria. So again, we're looking at a class effect in patients with established diabetic kidney disease, but we do not yet have solid data in prevention of diabetic kidney disease. What about the impact on the rate of decline of GFR? As I told you at the beginning, the natural age reduction is about 1 ml per minute per year. In diabetes without nephropathy, it's around about 2, and with those with established nephropathy, it's around about 4. And what we found is that in Credence, which has published these data, we see that canagliflozin, the rate of decline of GFR was about 3.2, and in the placebo, it was about 4.7. So it is a significant reduction of about 1/3 over the duration of time. Now, this again is a bit of a puzzle, because if we look at previous published data in the Credence type of population, and by that I mean the IDNT and renal studies, which I was involved in many years ago now, we're going back with to about 2001, you can see that RAAS blockade reduced the rate of loss of GFR to around about 2 to 4, which is pretty much the same as we're seeing with SGLT2 inhibition at 3.2. And yet the SGLT2 inhibition is on the background of RAAS blockade. All of the patients in the SGLT2 trials are already on RAAS blockade. So is SGLT2 inhibition adding anything to what you would expect from RAAS blockade in terms of rate of decline of GFR? And there's another study which was published in The Lancet just this month called SONAR, which is using atrasentan, which is an endothelin antagonist, and that also showed benefit very similar to what we saw with RAAS blockade. And that was also atrasentan on top of RAAS blockade. So have we got a situation where we've reached a level at which we can slow the rate of progression of GFR, and that we can't get anything more on top of that, simply because once the process is initiated, there are so many mechanisms which are driving the disease that blocking one or two of them can't actually affect overall rate of loss of GFR other than down to about 2 to 3 mLs per minute per year. Okay, so what can we conclude from all this data? Well, firstly, there's no doubt that SGLT2 inhibitors reduce albuminuria in established nephropathy, but probably as much as intensive RAAS blockade. They consistently, perhaps modestly, reduce important renal outcomes, including end-stage renal disease and mortality, and we shouldn't underestimate this effect, although the absolute numbers are not that huge. They reduce the rate of loss of eGFR similarly to RAS blockade and other agents and don't seem to provide added value. They don't seem to prevent new onset albuminuria. And we need much more information on the effect of the renal handling of creatinine by these agents, because we must remember that what we're using as outcome measures are all serum and urine creatinine based, and we don't yet know exactly what SGLT2 inhibitors do to the renal handling of creatinine in large numbers of patients. So we don't yet have that information, and David Cherney himself says in the discussion of several of his papers that we need this information to understand better how these agents work. So they are of positive benefit, but we still need a lot more understanding of how best to use these agents in terms of diabetic kidney disease. Thank you very much.
Thank you, sir, for your lucid presentation. We had two talks on, one on hypogonadism and another is diabetic kidney disease, use of SGLT2 inhibitors. We will open for the questions. I want to ask Dr. Richard that what is the genetic association between smell and gonads, and there is any role for the pheromones, because sex and smell is something related genetically.
So with Kalman syndrome, we know that it's caused by a genetic defect which prevents the olfactory, neurons from extending axons through the cribriform plate into the brain and connecting up. And that removes the pathway for the GnRH neurons. And therefore, they're there, they form, but they're marooned in the nose. They can never get to where they will be functionally active later in life. So in terms of pheromones, so we know that in animals, these are mediated via the accessory olfactory nerve, which would be the vomeronasal or terminal nerve. And the pheromone receptors sit in a thing called the vomeronasal organ. Now, the vomeronasal organ does also exist in humans. It opens into the nasal septum. The question that remains whether it is functional in humans or whether it's vestigial. One of the unfortunate things is that some of the major researchers in the field of pheromones, David Monty Block and one escapes me, they quickly went commercial. They basically, in a sense, abandoned their kind of, should we say, mainstream scientific research, formed the Ferring Corporation, and then went straight into commercially based research with a view that maybe they could make the Sex Me Up aftershave. And then when they kind of went into mainstream research, no one else has followed them. So I'm sorry, I can't say more about the vomeronasal organ and its function of pheromones in humans, except that the jury is still out on that.
My question is for the previous speaker, sir. In Kalman syndrome, when you treat, will the smell come back?
No, the smell will never come back. All you can do is replace the missing hormone, and the question is at what level. You can replace it at the bottom end, testosterone. You can replace it at the intermediate end, which is LH and FSH. Or if you have access to GnRH pump, you can replace it at the top end, but the sense of smell will never recover. Interestingly, about 5% of Kalman patients actually, for reasons that aren't clear, the hormone axis will recover later in life, albeit not necessarily permanently, mainly be a brief phenomenon. But even in them, once the smell's gone, it's gone.
And I would like to answer the chairperson's question also, sir. I'm a neurologist. This Kalman syndrome, loss of smell, is a common thing for both neurologists and endocrinologists. The neuroblast, actually there's no neuroepithelium of the nasal epithelium. It is a neuroblast which is between the neuroepithelium, epithelium and the neuron. And it is considered as a precursor of the neuron. And it can divide. It's the only thing that can divide. It's a premature cell. Once it becomes a mature cell, it's a neuron cell. So the hypothalamus was there in the nasal mucosa in the prenatal period, and it migrates into the skull. Because the migration is a property of the neurons. The 7th nerve nucleus migrates. Similarly, the 11th nerve, spinal axillary, also migrates down to the C5, whereas the cranial axillary is in the brainstem. So when they migrate into the skull, you have hypothalamus, and near the hypothalamus is the hippocampus. The olfactory circuit that starts from the axons of the neuroblast, then to the neuroblast, which is the first order neuron, and from the axons of the neuroblast through the cribriform plate into the olfactory bulb, where you have mitral cells, the second order neuron, and the axons of the second order neuron, they go on the same side as well as to the opposite side as a rule in neurology. So they go to the opposite side of the cingulate gyrus, then they come back and down to the hippocampus, then the amygdala, and finally end in the uncus or the pyriform lobe, which is the third order neuron. So as they come along with the hippocampus, they are also injured because there's an insult, prenatal insult, as you said, by genetic insult, isn't it? So this insult also affects the hippocampus, also affects the hypothalamus. So there's a GnRH deficiency, and here there's a smell, anosmia from the birth. And third thing is, this is ophthalmic, this is the olfactory circuit. The second circuit is a limbic circuit. The limbic circuit starts from the cingulate gyrus, again hippocampus, mammillary body, mammillothalamic tract to thalamus, then this corpus callosum above, and then the cingulate gyrus above. Cingulate to cingulate. That is a mammary, that's a limbic circuit which is responsible for your fear, fright, courtship, finding out your life partner, and then bringing out the offspring. And that is why there's a sexual problem, sexual deficit. Thank you, sir.
We did, years ago, we actually did olfactory epithelium biopsies on both normal volunteers and also on patients with hypochondriac and Kalman syndrome. And actually, we saw that actually there were, even in an adult, there are GnRH neurons still arising in the adult human olfactory epithelium.
So we are running very late. If there is any question for Dr. Bilous. Yeah.
So traditionally, we've been focusing on albuminuric nephropathy and type 2 diabetes, but increasingly we learned that there is a non-albuminuric component. The question is, and Credence did not really, none of these studies addressed the non-albuminuric nephropathy. So do you think that there's going to be a role of SGLT2 inhibitors in the non-albuminuric variant of nephropathy?
Okay, that's a really excellent question. In fact, the EMPA-REG renal team have published data based on efficacy according to baseline GFR, but and albuminuria, and it does look as though the efficacy of these agents in terms of cardiovascular outcomes is the same, independent of whether you have albuminuria at baseline or not. The cardiovascular event rate is much higher in albuminuric patients because they're at higher risk of cardiovascular disease. So it does look as though this is an SGLT2 effect across the range of albuminuria and across the range of EGFR. It just looks as though, because the event rate is much higher in albuminuric patients, the number of patients that are benefiting is greater.
Can I have a follow? So, but if you look at the LEADER trial, which the interesting thing was that the benefit, the cardiovascular benefit, was seen only in patients who had an eGFR of less than 60. there was no cardiovascular benefit in patients who had higher GEGFR. So you have on this one hand this tenuous link between albuminuria and CV disease, but benefit with drugs happening when the eGFRs are much lower.
Well, I'm not sure if I caught that completely, but as far as the cardiovascular outcomes are concerned, it's a consistent benefit whether your eGFR is above 90, 60 to 90, or less than 60. Because of the way that these drugs work, there have been very few patients with an eGFR below 30, and certainly there are a few between 30 and 45. But according to Cherney's analysis of EMPA-REG renal, although because the numbers are quite small, the statistical power starts to drop off. But the trend is the same across the range of baseline GFR and across the range of baseline albuminuria. So the drugs are working on their cardiovascular benefit irrespective of baseline kidney function. So is that answering your question?
Yes, and I'll take this up when you come down. Thank you.
Okay, I'm sorry if I haven't addressed that completely. I mean, I think my point about not preventing albuminuria, I think gives us a message about how these drugs are working and what is the importance of the mechanism by which they're working in terms of the evolution of diabetic kidney disease. So it may be that other mechanisms are much more important in initiating the kidney disease process. But once you've got kidney disease and albuminuria, then the hyperfiltration in remnant nephrons may be an important driving factor. So by inhibiting that hyperfiltration in established kidney disease, we are benefiting the patient. But what we're not able to show at the moment is by using these drugs in early diabetes, we can prevent kidney disease developing. And that's really the point that I was trying to make, and I'm sorry if I didn't make that clear in my talk.
So most of the observations were hypothetical. Most of your observations were hypothetical. So is it really, we are confident of handling that drug?
Sorry, we need to sort of move the discussion along. We have to take it offline. I'm very sorry, we're running very late. I'll ask him to... No, but I think you do need to respond to that.
I've got to answer that. I mean, what we did with these trials is come up with a hypothesis. We showed proof of concept in small numbers of patients in whom we showed that we can influence GFR and albuminuria, and then went to large-based trials where we showed a definite positive benefit in terms of those with established kidney disease. So this is not hypothetical. This is proof of concept. What we do not yet have are trial data to show that we can prevent the kidney disease coming out, but the trials weren't designed to do that in the first place anyway. So I think this is a great example of where you have an agent, you have a hypothesis, you have proof of concept in large multi-center RCTs. So I would dispute that this is just purely hypothesis.
Thank you very much, sir. We'll close the session. Thank you.
Thank you, chairpersons and speaker. So may I request Dr. Jayashree Gopal to present the memento to Dr. Richard Quinton. And Dr. PG Sundaraman, sir, to Dr. Rudolph. So, may I request Krishna to present the memento to Dr. Jayashree Gopal and Dr. PG Sundaraman, sir.